Thank you very much. And as mentioned by Professor Mesut, while I was planning this presentation, I would be approaching this subject from the perspective of pharmacology. Perhaps you might know it very well, but I'm aiming to tackle with the basis of this just to make a reminder. And also, Mr. Adnan would be elaborating on his clinical experiences. And psychiatric diseases are as a whole have variety. And there are general definitions, subgroups, specific groups, special groups are also included. When this is the case, we come up with a very complex scene or picture. And while we tackle with such diseases, cope with them, the different aspects of the drug molecules and as well as the effects of these drugs on certain pathways through markers, certain markers, and also with the knowledge introduced into literature are all evaluated, and accordingly we get certain plans for treatments. And the fundamental aspect is the distorted the quality of life, and the people try to survive with the negative quality in their lives, and we try to improve the condition of these patients with our interventions. And just primarily with the depression, I guess that in this wouldn't be wrong to generalize as all psychiatric conditions. We start with a certain drug, and most of the time we get a response by one third, and then a second one is started, and it might be the case that we wouldn't get good response with the second one. When we go with the third one, then we might lose our chance more. So for that reason, almost there is an one third resistance is in could be discussed. And more important than all these, the ones who stop the treatment, and the people experience severe side effects and their condition. So in terms of the treatment, there are very problematic, and in order to get a response for the antipsychotics, these patients who have compliance problems, we ask them to wait for weeks. And if you would just remember the development of the drug development, so in order to access to the molecule of drugs, we actually 10,000 compounds go through preclinical studies, and then they're reduced to 250 compounds. And of course, there is a difference between the human and animal brains. And in terms of the applicability to the clinic, we have got disadvantages, and I do not even talk about the models and so on and so forth. When the molecule comes to the clinic, so it is approximately 5, and through within these clinical phases, they're stuck in one or two of them, and then we get out of this and treatment. And this is really a very important time, as well as a long time and cost as well. And if there is a right diagnosis, and if even if the right approaches are executed, uh, this might be about 50%. There might be a problem of resistance by 50%. And in terms of the pharmacoeconomy, we're not only talking about the investment costs or as well as the expenses made for the patient, but we're also talking about the loss of the labor force as well as other aspects, and this is very expensive for the economy in the country. Within our life, we're always fixing something, but for that specific screw, we're just going for the right device, and we never go for the wrong key. And then if we would get something, buy something, we always opt for the one that we are comfortable with. But when it is time for health, we are actually we try to progress with the standard protocols and standard protocols and approaches, and so for that reason, I think it's impossible that one size fits all. And there are many omic factors. Uh, I will not go into the details. There are many personal factors, the environmental factors as well, when they are all included into the process. And also, this might be foreseen, of course, envisaged. And age is an factor on its own, and also the gender, and also the hereditary conditions, and if the patient is using for more than one drug, and also the genetic factors, as well as the differences in the characterization of the patient, indeed would certainly affect the result of our treatment. And apart from this, there are similar things that would constitute the side effects, or nutrition, pharmacokinetic aspects, ethnical factors, neurotransmitter levels, and also the brain bowel axis. We're talking about a gut microbiome, and also inflammation. Also, when these are all involved, we know that we are coming across with severe effects of the drugs. So when a drug is prescribed, actually, the patient or physicians are exposed to a sphere, very important testing. And without seeing these variables, and without evaluating these factors, drafting, prescribing, and prescription, and foreseeing good result is not very likely. So there are many studies ongoing, and all, and literature, in literature there's an accumulation of big knowledge, especially the regional differences. We have learned a lot very well. So of course we have to utilize this data for the well-being of the patients, and for a group of patients, when we prescribe the drugs for them, we get an impact, and then influence. And in the other group, it might be the case that we don't see any impact, influence. However, in the other group, we might see adverse effects with the same drug. On the other side, in the group where we get a response, there is an important, significant variables, a variety, and in order to get a good result, we try to adjust the doses, and then we need to go for the individualized and personalized treatment. And so for that reason, both pharmacokinetics and pharmacodynamics, polymorphism in the pharmacotherapy, psychotherapy, we need to get the polymorphism in those domains, and we have the drug adjustments, dosage, dosing intervals, as well as the parameters that will be used in follow-up, and the treatment strategic or therapeutic strategies are also to be listed. And for that reason, for both pharmacokinetics and pharmacodynamics, we need to tackle the issue from these both aspects. And I like using these expressions. Pharmacokinetics in general, it's about what the drug does to our body, and pharmacodynamic is what our body does to the drug. And within this scope, we see that in all levels, stages of pharmacokinetics, in all levels, stages of absorption, distribution, and metabolism and excretion, there are genetic differences. And from this perspective of pharmacodynamic, when we look into the information, we see that the receptors as well as the transmitter receptors, and as well as the polymorphisms. And just to make a general reminder, a drug that is taken orally goes to the stomach, and then it is exposed to the solution, and this and since that there is a big surface, it is absorbed in the small intestines, and then goes to the liver, and the liver metabolizes, and it is not yet in the big circulation. So for that reason, without reaching the effects, it is metabolized in liver, and we call it first mass metabolism, and we don't like it because this decreases the bio benefit of the drug, and then it goes into the big circulation, and it goes to the places where it would create the effect, and then secondly it comes the second time to the liver to metabolize, and then it turns out to be a metabolized, and then it is taken away from the body. So every drug goes to the livers twice, and both of them macrosomal enzymes are faced with changes molecules in phase 1 reactions mostly, and it goes from cytochrome P450 system. They either oxidize or they expose to reduction, and then we have in the phase 3 second system we have the conjugation. So according to the metabolite, if it is a pre-drug, then it turns out to be an active compound, or the normal drug molecule is inactive, or toxic metabolite can emerge, and an oral drug is metabolized, and it is a peak concentration. It means that it's the slice of the light. After it comes to this point, it is absorbed, and afterwards it is distributed and then metabolized. And this part under the curve, actually, it tells about the bio-benefit of the drug, and area under the curve. For example, the B drug here, therapeutic concentration. So for that reason, we get an effect in the patient, and the A drug goes up with the high concentration, and the patient has toxic symptoms. And C is the sub-concentration, so there is no effect observed clinically. So this curve for the therapeutic index narrow is more important for these drugs, because very small drug doses, either it has a sub-dose effect or the toxic effect. As I have just mentioned, the factors that change the factors that change the drug because of the features of the organism. In the drug metabolism, there's a difference that takes place, and then both pharmacokinetics and or pharmacodynamic parameters differ from each other greatly. So I would like to draw your attention here in this graphic. There are moderate scores just against time on the basis of the weeks. All patients are taking the same dose at the same time, and there is a big confusion or complexity, isn't it? There is no improvement at all, and there are also ones who give a good response to their drugs. So for that reason here, the fundamental and basic factor is about the polymorphism, and one or more enzymes or pharmacodynamic parameters are depend on this, or these are dependent on the polymorphism, because in the population where we give the drug along with the ones that we get the response in rational pharmacotherapy, we try to identify the best drug with the best dose, and despite this, in one of the cases, we might not get a response. So what we have to look into back, it is about the differences in pharmacogenetic. So we have to evaluate all the aspects here. So for that reason, especially in the cytochrome P450 enzymes are important, and further beyond or more, when we look into the drug metabolism, we see that this system with 50 different isomes have got 7 and 11 members, and these are taking their role in the drug metabolism, and some subtypes would play a role in the subtypes. So these enzymes, again, there's a single nucleotide polymorphism number is quite high. So in all isoforms, this is valid. So for that reason, pharmacokinetic, some genes pharmacokinetically, as we have just mentioned before, the concentration time graphics, the bioavailability of the patient come out to be the effective factors, as mentioned by Mr. Mesut. The metabolism rapid being so too high are actually stay at the sub-effective dose. The ones at the moderate level, we see a response, and in the ones which cannot metabolize, we see the adverse and side effects. And at the beginning of 2000s, Kirshiner et al., they carried out consecutive studies, and they've got great papers in terms of antipsychotics and antidepressants. This is one of the most comprehensive studies indeed. And here in SIP2 C19, the drugs that are used in psychiatry, the enzymes, the polymorphism in this is dependent on the metabolism speed of the patient. The doses are identified. Each of them, we are talking about very important and very strict doses of the drug to get a good response. So here, if it might be single nucleotide polymorphism, and it might even be seen as certain very less percentages, and in such of them the situation would be very dramatic. So I would like to give an example. For example, to the patients, 25 milligram nortriptyline would be given, and we would be following their blood concentration for 72 hours. If there is a function, if there is no functional disorder in the gene, the area under the curve, we see that the patient is under the therapeutic response and the number of the polymorphisms. So accordingly, there is a difference in the functions. We see that the effect gets less, and we see the area under the curve gets less and less, and it's really a dramatic example here. On the other hand, cytochrome P450 enzymes under different conditions, for example, smoking, or environmental pollution, or the grapefruit juice, by many different drugs or environmental factors might impact or influence, and then they may be inhibited, or they might be affected. So at the speed of the train, they can be metabolized, or not only the genetic differences, but also the other drugs or the life habits. Because of life habits, cytochrome P450 enzymes activity might have been changed very significantly. And now the genetic factors, to which extent they impact the treatment results. And there are a lot of studies on this. And as of the 1990s, all these studies were accumulated, the family meta-analysis, and give us results. Indeed, currently, still shows the reasons, and researchers and searches for the reasons for this resistance for the drugs. And on the other hand, specific to the psychiatry, schizophrenia, major depression, bipolar disorders commonly seen, there are certain intersection points in terms of the genetics. It might rise from 30% to 70%, and these are really, really dramatic levels and rates, and for sure that they are predicting the outcomes of the treatment. So this actually, there should be a strategy that would start with the development of the drug, especially the clinical stages, and pharmacogenetic should be integrated much better. For that reason, before the drug is introduced into the market, the envisages should be in hand. I think that this might be taken into consideration for the future. But where we stand right now, we already have past 30 years. So this thinking that I have prepared this slide, and there are questions that we have to answer. How much the clinicians use these tests, whether the patient is really benefiting from it, and whether this increases the drug safety, and also whether the drug therapy has been improved, and the personalization, the use of the genetic test as well as personalization. So not only we're talking about the selection or of the drug, but we also have to combine it with the genes. We're in this part now, so everyone would be able to get an individualized therapy, and our genetic differences would no longer be a fate, but the patients would get a better result that they deserve. And I would like to end my presentation saying so. Thank you very much.